So with your homework, what did we learn this week? Left 2 weeks since I gave you a week off. First thing that we should have learned.
COPD eaters have lower values. That's the normal. Can be managed.
Lower what value?
It has lower PaO2.
Or PAC. Okay.
They're acidic
Why are they so?
because they have more CO2.
And then I exchanged it again.
Okay.
Or distress kind of thing.
I do have a question though.
Mhm.
Whenever we're talking about the partial pressures and stuff, I got a lot of my information from ABGs. Would that be about like a good resource to like look at?
That's how you get.
Okay. That's everything that I found is about ABGs.
Yep. I mean, that's the only way to get them.
Mhm.
So,
Okay.
what have we learned is the difference between your PaO2 and your SA?
Arterial and venous.
That's a good start. So, which one's which?
Your arterial is the more accurate.
By how much?
Not much, but
So it's like 3 to 5%. So it's negligible when we're dealing with these values. So when we do iStats here, we do obviously a venous, and it's not going to be a difference for us to treat or not treat, to treat or withhold treatment between an ABG or a venous blood. We're talking negligible points.
we're not supposed to start art lines anyways.
Um,
We're not supposed to draw art lines or start art lines.
Yeah, it can be an issue. Next year we'll be able to because we'll have to. But typically you don't see art lines done in the field just because they're dangerous or have the potential to be dangerous. However, understanding during your clinical time, lab lines is going to be very, and it's going to be important for the rest of your career if you stay within EMS, because we know some of you do. But not every run we're going to do is going to be a 911. And even if it is, we can have a 911 from nursing home. You can have this urgent transfer. You can be taking those transports that our people are already on the bed. I know somewhere down in Jeff or Albany or Floyd or somewhere around the nursing home, it's like full of bed patients, right? Like that's just where they all are at the farm, all laid out in the pasture there. So even though this may not be something that you typically do as far as transfers like our service does, you have the potential to run into this quite frequently. But either way, how many of you can implement a vent in the field? Okay, your service can, not you, man. Okay, so majority of us, right? How many of you take transfers for a service that if they come up, then you take them? You just put out fire and save dogs. So everybody except Joseph will use this in your career. So Joseph realizes that EMS is significantly better than the fire department. But understanding what these values are, how they work, and where they're produced is going to be the big thing. So the first thing that we're going to go back over is going to be Krebs. We're not going over Krebs in its entirety, but we're going to understand how. I guess let me ask you this to see if we need to go through. Where does our values of CO2 come from?
Metabolism.
Also known as respiration. Type of respiration. Internal.
Intracellular.
Cellular respiration, also known as the Krebs cycle. So we all understand that you've got the Krebs cycle take place in what? So when we go through the Krebs cycle, and we're dealing with how many ATPs we produce?
We produce 2.
Airway.
Oh, Airway,
Oh, that's it.
yeah, are we taking into the net value or the whole value?
What's that?
Was it 34?
38 is our gross value for ATP. But how many ATP does it take to achieve this cyclic cycle? Okay, so we produce 38, but the process itself uses 2 energy, right? So we end up with a net positive of 36 ATP. Now, does anybody know, we should because we went over A and P, how do we get to this point? How does ATP happen? What do we use in the body to produce ATP? Where does this process come from? Okay, which comes from where?
It comes from,
Glycolysis.
So you have glycolysis, right? That then turns into what, Jackie?
Paramedic acid.
So you have, for simple terms here, how many glucose do we start with here? 1, good. How many pyruvic acid do we get after the glycolysis occurs? 2, 4, 2. Good. So you have 2 strains of pyruvic acid that are going to go through the Krebs cycle. You have 2 of them. Now, with this, this is where we get everything that's happening in our bodies through Krebs. And the reason that this is important is because we can control 90% of it by breathing, ventilation, positive pressures, invasive pressures, non-invasive pressure, all of those things within the body. So when this goes through, does anybody know what this breaks down into? Or what byproducts we get? Okay?
Also CO2.
Okay? And we said what?
CO2.
What else?
O2 and water.
Oh, boy. O2 and water would be wrong.
It's just O2.
Hydrogen.
Maybe like GTP or something like that.
Yeah, GTP. Get 2 other things. These things, extremely important. You get something called NADH plus and FADH plus. Anybody know what these are? Okay. NADH is niacin, which is what? What is niacin? A what?
Inside.
B vitamin. What is riboflavin? Anybody know? Also, a B vitamin. So, now, in this stage, it's not a B vitamin. When it binds to this hydrogen, it becomes the full B vitamin. These right here are going to be the root layer for your niacin and your riboflavin. Okay? Now, why are these important? Any idea, Gage?
You need vitamin B for muscle breathing.
Hmm?
You need your vitamin B to help produce muscle breathing.
You need these B vitamins to not only help with your body function, but for this combination here to happen, your body has a process called oxidation phosphorylation. Now, this is important, but it's not. Understanding exactly what is happening at your level, which level is going to be, is not as important as understanding what happens if oxidative phosphorylation doesn't happen. Does that make sense? Okay, so oxidative phosphorylation, 5 complexes, with 2 Gary. Okay. Understanding what is happening during this, which I'm going to go over, is not as important as understanding what happens in the body if it doesn't. So you have occurrences. It's great. So when you have, so think of that as cellular membrane. With those high artistic abilities, it should make sense, right? So this black part here is going to be a permeable membrane, okay, of the cell. Can anybody tell me what we end up with here? Anybody, by chance, know? Huh?
Is there fluid? Oh,
that equal?
ATP
ADP plus P.
is,
So this is how we produce our ATP. The process of oxidative phosphorylation is actually how we end up ATP. We end up with the ADP plus an extra phosphate through what's happening here. Again, understanding how we get there is not as important as understanding what happens. This doesn't happen. So we already mentioned, we'll say, this isn't completely accurate, but for comprehension purposes, say that this is inside, this is the cell membrane, and this is outside. Through our thread, what did we say one of our main byproducts here that's highly important? Hydrogen. So you have all of these hydrogen inside. So complex one is going to be where these hydrogens start binding to that NAD. That's where you're going to start producing these knives, right? So you'll have some of these hydrogens start moving into here, right? In complex two is where you have some of these hydrogens start moving in and creating your riboplates, okay? They're going to start moving in and binding with that FADH. Okay, so that's where these are going to start happening. You have two coenzyme factors in here that are going to help break down and facilitate this. Not important to understand, just letting you know there's two little things in there that are shutting stuff off. Okay, each time we go through one of these processes, right, this hydrogen keeps moving further and further into this membrane until we get to where we have this balance of where all of this is outside the cell. And why is that important?
And that gives us the hydrogen for the crib, or is that?
That's bio. Why is this important? Think about when we use this, what are we actually breathing on? And what?
Hyper,
Breathing on.
carbonic,
Somebody just said it. Water. Water. What is all this free radical oxygen going to bind to in our body? The free radical hydrogen, right? That's how we are going to get to breathe off this end type. If we have a lack of oxygen and we don't have oxygen for this hydrogen to bind to, then what do we get? Does that make sense? Do you understand how we're getting it? If the hydrogen doesn't have something to bind to, it becomes acid, it creates acidosis within the body because we're not binding it with oxygen to breathe off. And the hydrogen is going to stay within these cells or within the bloodstream and make that bloodstream more acidotic. We get that? So when we're dealing with this, it is really important, again, not understanding exactly what's happening at these stages, but understanding that this is how we get to here, right? The byproduct of this whole process is going to be this, right? And that's what? Exactly what we're breathing on. So when we have a disruption of this oxidative phosphorylation is where we have to step in. Anything that I can clarify before we move on to this? We're going to refer back to it. But again, I want you to have a basis of where we're starting. Does anybody want to take a minute to write down what's up here?
question actually. So you said that whenever the H goes on the outside, does the NAD and the FAD go into the oxidative phosphorylation?
That's what gets in ready.
The whole thing is?
Your complex one
Yeah.
is your NADH
Oh,
that
okay.
binds to your hydrogen. Complex 2 is your FADH that binds to your hydrogen. Your complex 3 is the breakdown of where the hydrogen moves. Complex 4 has to do with this coenzyme efficient. And then complex 5 is where you end up with ADP plus phosphorus as byproduct. That's where we get our energy.
Oh.
So this is complex 1, complex 2, complex 3, complex 4, and our final result, complex 5, the coefficient. Those are not important. Anybody have payments? So again, you don't need to know each complex, you don't need to understand the process that happens in each complex, you just need to understand there are 5 complexes that happen here. We start with one, we end up with this ATP synthase, which produces our ATP for our energy in our body. That's what we need to understand. And we need to understand if we can't get this byproduct of this hydrogen out, what's going to happen? It's going to become toxic for the cell and kill the cell, right? Because it can't get that hydrogen out. Now, when might we see this happen? Perfect. Cyanide. Because what does cyanide, I won't say prevent, what does it block?
Blocking the hydrogen moving through the liver.
No.
The coenzyme, when
Cyanide is going to block the ability, it has a guard, a safeguard, that's going to inhibit B enzymes. And what are these? Huh?
So he's not making vitamin B, or is it?
Correct. We have the inability for these to bind with this hydrogen to create these B vitamins. And what's going to happen to all that hydrogen?
Stack up in the body.
And what has a 200 times greater affinity to hemoglobin than oxygen?
So does that mean your body's just stacking B vitamins, just can't use them?
No, it's not creating them. It's starting to stack hydrogen. You cannot bind to your hemoglobin and you suffocate. Does that make sense? So you have your hemoglobin, right?
Is just that you need the B vitamins to get the hydrogen outside the membrane. So
So the hydrogen will still pass through the membrane, but they're not being absorbed. They're not being utilized. So you just have this huge rush of hydrogen going out, greater amounts than it should be. It's like being, like if our classroom capacity is 200 in here and we got 500 people, but 300 of them are walking through, then we're at fine, right? But when I lock that door, now we have all these people, we can't be in here, right? We are saturating the bloodstream with hydrogen. So on our hemoglobin, how many binding sites do we have? 4, right? So with cyanide poisoning, what's happening is all of these hydrogens are going to be binding to these seats, not allowing the O2 to bind to the hemoglobin. So we have, with cyanide poisoning, thinking back to our homework, why is it difficult for us to possibly catch
reason
this? Because what are we measuring? Correct. All we're measuring is, it doesn't say, hey, this is hydrogen, oxygen versus hydrogen. This is saying it is saturated.
So would it be more likely to catch that with our CO reading or our EC2?
Yes.
It would be really high.
Because on this, if you have a cyanide poisoning, you're gonna have this value. Right? Because what's happening?
It's dead.
Everything's saturated. It's saying good to go. Right? But what is this going to do? Through the roof. You might see values of higher than 100. So not only with this, are you going to see both elevated values on here, which is going to tell me something wrong, because that shouldn't be that way. But where are we gonna be able to start helping with this? Or not? Cyanide poisoning, if you don't have the antidote for it, they're done. That we can, there's no amount of FiO2 that we can push in them to offset. Because all we're doing is causing free radical oxygen in the bloodstream. Here, what we need is a B vitamin coefficient, subjugating this blockade, start allowing us to produce these B vitamins to absorb the hydrogen. So there's no amount of FiO2 that's going to solve.
I like the Sino kid, is that like usually one dose fixes it temporarily, or is that something like they need a multi-dose?
Typically, you're seeing those people, I mean, obviously, it's going to depend on the amount of exposure, but typically those people have to get repeat doses. Now, a dose off the pump,
So we make it in time.
yeah, I mean, this is a very quick process. We're talking minutes. Very few minutes. And it's a grave and great possibility. If you're right place, right time, you're also right place, wrong time, because you've probably also been exposed to cyanide. So now I'm like, thank you. You're gonna say to yourself, should have brought your own kit, dude. Like that's where you're at.
Be a very dumb question, but I know
Possibly.
thiamine is like a vitamin B. Can that be used in any situation for cyanide?
Yes and no. You can help. So you're introducing B12. Body breaks down this B12 into other vitamins. You have the ability to possibly absorb some of it to offset. But you can, I mean, through the dark, it's not gonna hurt. Well vitaminized during their calming. But I mean, at that point, shoot your shot. Anything else I can clarify up here? Everybody understand?
No, I was looking at it.
So other than like cyanide poisoning or anything else that can stop this process from,
Yes, but they're rare. But this whole process here can be affected on the daily. This is when we're dealing with COPD, injury patients, whatever. This is what's being affected. This is how we're going to get those raised M-type over those raised lactics or the lower lactics. It's all because of this process here. This is where everything in the body is going to be built up. These ABGs, these lab values, these lactic values, all of these things, this is where it starts, and this is why it's important to go. This is all critical care level stuff here, but this is one thing I was never taught during my medic class, so I always had this like, how the fuck did we get here? Thought, right? Like understanding at a cellular level and what we're doing to fix it. So again, that's why I'm not going over these 5 complexes. You just need to understand this is what it's called. This is what happens and what happens if it doesn't. But that's why I'm not going over this in depth, but giving you a layer of where it starts, I feel like is important. Because we can't just understand what we need to do to fix it. We need to understand why we're doing it and what we're doing to fix it and what's happening with the body. This goes back to day 1 of tracing a drop of blood. Understanding where blood is going and coming into is important because while we're dealing with alveolar capillary beds or tertiary capillary beds, that gas exchange and all of that, this is no different. This shit happens if you're in the body. Alveoli, beds, muscle structure. Okay. What about holding focus creating the goal? Anybody want a break real quick? Like, cause I know this shit's gonna be heavy and I know we'll probably need a lot of short breaks, so I'm happy to do that. So you tell me if we want 5 minutes just to reset for the next thing, or we're good. Good? Okay. So the next thing that we're gonna need to go over is going to be, I need to make sure I got this. Yes. So the next thing that we need to go over is going to be give Cindy this note. That she did. So we're gonna send that one back. It's good. Want to go into acid-base balance? You want to go to the oxyhemoglobin? Oxyhemoglobin. Yes. It's not.
Okay, full tent, we got another one.
What was the first one you said?
Yes.
Is that kind of going off of the carbonic formula?
Hmm?
Is it also formula?
We've got an extra one.
I do.
Or
You want this one, you want this one back? I don't want it front.
I'll just need it for a second. So I know what I'm doing. One thing is.
I'm going to see when I shift.
It's what it is.
I mean, good stuff.
A little bit.
So, new definitions. And um, going into. So, mean values that I give you for your home.
Nitrogen, oxygen, carbon dioxide, and water.
And what about your other ones?
Everything that you wrote.
Um,
Nitrogen, CO2, O2, SaO2, PaO2, NaCO2, PaCO2.
So these are going to be the first. Anything with a P is going to be one.
Paramedic.
Partial pressure. Who can tell me what exactly partial pressure is? Huh?
Pressure exerted by
Do that
each one of the
I want
You're 99. So a partial pressure, pressure pressure of gases within the blood on the arterial side. Okay. So anything with a P is going to be from the heart. So for us, where are we going to see that? This is where we're going to see these values off of ABG. Now, again, like I said earlier, if you're getting a value of, let's say, you do an ISTAT here, right? During your time, and you get a PaO2 of 64%. Right? If they're going to be, and we're not taking 3% off of this number, we're taking 3% off of this. Okay, so what's 0.64 minus 3%? Anybody know? Is there a big difference between those two? Because that's going to turn into like, it's actually going to turn into 0.62 or something, or 6.6262 or something like that. So that's going to equate, right? So we're talking about 1% difference at most with it. So am I going to treat this different than I'm going to treat this? So while an ABG is highly more accurate, if you have point of care in the field or the ability to do point of care, use the values that you can. But yes, partial pressures are on the arterial side, okay? So what does that mean for us?
The blood at leak pressure, that's the value we're going off of.
Just anything. Even if we're looking at, let's say, vent patient transfer that we've got. Typically we're gonna ask for ABGs. Ask ABGs that we go. What are we looking at?
We're looking at how well the body is still.
How they're either, and we're gonna come back to this, but this is where we're going to get this value from. Now, how many of you have seen that term during your homework? 2. Okay. Can anybody tell me what the V stands for?
Ventilation.
Okay, the V is going to stand for ventilation. Can anybody tell me what the Q stands for? Perfusion. So, when we have a VQ mismatch, that means we have a ventilation to perfusion issue. That means we have something is not balancing out here, so we end up with a ventilation perfusion issue. And those are the things that we need to correct,
So
okay?
that's the whole, like, they're venting, but they're not perfusing because of the gas exchange happening, which.
It could be gas exchange, it could be hypovolemia, it could be hypertension, it could be increased thoracic pressure. That's for us to figure out why we have a VQ mismatch, right? But there can be a world of things that can cause that VQ mismatch. We have to be able to identify there is a VQ mismatch.
This is telling us there's a, like, mechanical versus.
Perfusibility. Yep. So how many, we've done some of these partial pressures. So, we got different readings. So I know you guys did PO2 or PaO2, right? So your PO2 is going to be what? That is going to be 104 is the correct answer, but typically you're lying. Yeah, stop it. So how do we get to 104? Can anybody tell me? This is kind of a little kicker. That's kind of fun to know. But can anybody tell me how we get to 104?
That's how many sites the hemoglobin have to bond to.
As a test, you do a different way.
So, getting a little off topic, but it is good to know. So when we deal with, when we deal with these partial pressures, this is all based off of this. You know what that stands for? And our baseline for us is going to be what? You guys already joking back there? Sea level is going to be how many atmospheres?
For the atmospheric pressures. 4,000 feet above the.
There's changes with those.
Then
So, I'll get into that. So, let me stop, so I don't get sideways. So, when we're dealing with one atmosphere, anybody tell me what the pressure of the atmosphere is at sea level? 760. Now, this is what the base of how we get to our 104. Because what is atmospheric oxygen at? 21%. So 760 times 0.21 is going to equal what? No. 159.6. Okay? Now you're like, that doesn't equal 4. You're correct. So, what else is in the air? The main thing is what? Not gas in the air itself. Water vapor is going to be your number one coefficient in the air, which is going to be roughly 45 millimeters of mercury, or 45 total. Okay? Then, another about, and this is guesstimated, roughly 10 millimeters of mercury of nitrogen, CO2, etc. Right? So now do that math. What is 159.6 minus 55? 104.6. That's how we get to the amount of oxygen at sea level. Now, back to what you said. You have different values depending on whether you're not at sea level. So everything. So typically, we like when we do calculations, we start at 0. It's never been put up to take.
Like the first responder, active danger, 25 and 4. South Parker Lane, 554 South Parker Lane, Lexington.
Okay, so now going back to what Travis said. Now, are we at the same pressure here as we would be in Denver, Colorado? Denver, Colorado is probably how, anybody know?
It's a mile.
I was mine.
About a little over 5,000 feet, between 5,000 and 6,000 feet, hence the name mile high, right? So for every 1,500 feet that you go up in elevation, Now-
I just going to another teacher at the time.
this, you have to understand, this is from sea level, or where we're starting, okay? So this is huge in flight physiology, whether it be fixed wing, roto aircraft, or any of that. But on a lot of, here, not so much, we're a pretty flat state. But you've got a lot of areas that, West Virginia, even your Carolinas and stuff, that part of the state is flat, and then you go to the Appalachians and you have this elevation change. And to us, we're like, elevation change is fucking stupid. It is here, it's not other places, okay? So you have to understand that, you have to know, hey, if I have to go through this huge mountain pass and we go up 3,000 feet at our highest point, and we come back down on the other side of the mountain, we're going to have a huge elevation change for us, right? So for every 1,500 feet, you lose about 5% of your atmospheric FiO2. Now, that can be important, when you're doing transfers, or if you move on to do flight or something like that, you're gonna have to know this. They say some books are gonna tell you 1,000, some are gonna tell you 1,500, but, you know, at the same point, anybody know what a normal fixed wing aircraft cruise is at?
10,000 feet.
10,000 feet for your normal ones, your big commercials will go up to 30, 40,000 feet. But your normal aircraft would be 10,000 feet. Now, that doesn't really concern you at first because you have a pressurized cabin. So atmosphere stays typically the same. But if you lose pressurization, it's a huge issue. Now, if you go to your rotor wing or your helicopters, you don't have a pressurized cabin. What do those typically cruise at? Anybody know? Besides Charlie? Roughly 2,000 feet. Is that going to be a change for us? Yes. Not only from an FiO2 standpoint, which we're gonna get into, but also, so you've got a couple laws that are going to teach you gas. So the big two are Henry's and Boyle's, okay? So, this deals with Boyle's law. So if we go to intubate somebody, where is one place besides the patient that we deal with what we would call gas? No. Think about going through the process of an ET tube. I'm gonna draw an ET tube. What'd you say? Good answer. 2 points for you. What is right here? Cup, right? So, what is that cup filled with? And if we raise an elevation 2,000 feet, what is happening to this cup?
Pressure is changing.
The pressure is changing. Is it gonna go up inside that cup or down?
Is the pressure changing inside, like pushing on the cup, or is it the actual pressure inside the cup change?
Perfect question. The atmospheric pressure that's pushing on that balloon is becoming less, causing the balloon to do what? Expand, right? So right now, we've got atmosphere pushing on this balloon, right? Pushing down. We go up 2,000 feet, there's less, causing that balloon to expand. Now you're like, why is that a problem? It's not, but it's the patient's problem that you're going to hand off, right? So if we just sit here and take 10 cc's and slam that shit full of air, we have no way to read the pressure inside that cuff, right? So if we overinflate that cuff and then they go 2,000, 2,500 feet in the air, what is that cuff gonna do? It can cause esophageal collapse, it can cause trauma to that airway, it can cause that balloon to pop. And now we've got a dislodged ET tube.
just from my own weird and trying to understand. When we're talking about going from like sea level to 1,500 feet, I'm good there, it's pretty simple. But if you're already, let's say, up on if you're in Denver and you're already up a mile, and then you go another 2,000, are you having to subtract the difference, or you just?
If you're in Denver, you're still starting at sea level, because that is the norm, that is the basic. Correct. So you don't have to go through an equation of, this is where you're gonna start all of the times. Everything is going to be, this is what the atmosphere is. Obviously there, it's gonna be variably different. This 104 is gonna go down to like 99.8 from this 104.6, right? That's not huge, but understanding the further you go up, it's going to be, that's the part to understand. So, you know, we're not gonna have to go through this whole math equation when we do something. But to understand there's a variable change in atmospheric pressure, especially, again, here, not so much. But if you go on a flight or you go on to live in another part of the United States that isn't like a 11-year-old girl, then you're going to have to understand that you are going to have to deal with this. There's no way around it. So what can we do? We got our little tubey here, right? We got our little, right? How can we subjugate this issue?
If you left the string attached, would it kind of push out the air?
You can do that, but the dangerous part about that is bumping it, or if there is, you know, if they cough, what happens to those muscles? They're gonna contract on it, it's gonna push air.
Just draw something out.
So they actually make,
Do they have those little pressure readers for?
yeah, they're manometers that are a syringe that tell you, you connect it and you push it in, and there's a little reading on there that tells you this is what the value is within that cup. As long as you stay within that 25 to 30 millimeters of mercury, unless you go to like 25,000 plus, you're not gonna have an issue. So there's that. So on the flip side of this, so we know how to ventilate these patients, right? We're going to know, but at the end of the day, but we're understanding that 104 is our available oxygen in the atmosphere. So when we're dealing with some of these people, whether it be, you know, altitude sickness or anything like that, you know, if we leave here, right, and then Jesus decided to plop down a big ass mountain in the middle of Scottsburg, right, and was like, climate, are we going to, let's say the terrain is, it's steps, like the beginning of Ace Ventura, clear pathway of steps. But it's 1.5 miles or 2 miles into the sky. When we start climbing that mountain, is our body going to be able to transition that quickly? Yeah. Because why?
That's oxygen availability.
Less oxygen availability and less what?
Nothing.
Less atmospheric pressure that is compressing that gas, right? So that's what's happening when we're talking about atmospheric pressure. So we're not breathing during seizures, so something will.
Or the house behind or something.
Happy birthday. Okay, so at sea level, you have a very compressed gas, right? Is the availability of oxygen changing if we go up the atmosphere?
Smaller advice.
What's happening?
Walking down the road.
What's happening is going to be how compressed that gas is. Does that make more sense? The saturation of oxygen itself is the same, it's just how available is it in this square millimeter or square centimeter, however you want to measure it. So that's why it's difficult, is when we're breathing it in, the pressure is not as much coming in. Those gases are less compressed, meaning they're more expanded. And this is where, so where we get into deal with,
When you pull in.
this is where we start dealing with nitrogen. Because you've got O2 here, right? And then is nitrogen a bigger gas or a smaller gas than oxygen? Significantly bigger. 50-50 shot. Significantly bigger. It will, when we're dealing with, we're talking about atmospheric air, right? We already established 21% is O2. Anybody know what the other coefficients are?
It's gotta be like nitrogen.
And then your other 1% is something else again.
So the gimmick of filling your tires with nitrogen that actually works.
You're dealing with gas wall, yeah. Especially there's less room for it to expand because the molecules are bigger, so you don't have that winter, summer expansion. So this is what we're dealing with atmosphere. Now, one thing, while we don't have a lot of mountains here, what do we have quite a bit of, especially for you Kentucky folk? Not just caves, typically. What comes along typically with caves?
Sinkholes.
Think about, now, we're not gonna go into gas law, but think of one thing that comes along with gas.
Hit methane. Settlement.
Cave diving.
Diving. You have a lot of lakes. But you keep diving. So
Diving in caves.
this is where you have a huge change. This is why diving incidents can be so dangerous, because this makes it significantly difficult for us to rectify. At 33 feet, we drop an atmosphere. Another 33 feet, we drop an atmosphere. This now, while 33 feet, some people can free dive 33 feet. But some people do not. Now, thinking of this, if I dive down, so anybody in here certified to dive? So when you dive down, you have differentials typically when you start to dive. You can say, I can dive up to this many feet, because you have to train your body to do so. That's why when you start to dive, you start with all this equipment on and you're in a 10-foot pool. Yeah. Because there is no atmospheric change at 10 feet. It gets you used to the gear and all of that. But that's why there are different classes or grades of diving license, because if I can get my diving license and go, Titanic, let's go, I'm an idiot, number one, and I'm not gonna survive. But, you have to train your body to do that. So if we're dealing with a diving incident, we have to consider that there is all that compressed gas and the expanded gas within their bloodstream that is going to be extremely difficult for us to burn. Decompression chambers, because they can get the bends, and what happens when that happens? All that nitrogen expands so quickly and then your eyes pop. You ever go fishing and you like reel up a fish really quick and you come out with out of its head? You ever seen that? Google it right now. Fish eyes bug out reeling up too fast.
Whenever we go fishing in the ocean, where we're fishing at like 400 feet deep, when you reel them up, they're all bloated, eyes gone.
Their eyes are usually popped out of their head. You can put them back in.
Pretty much, because you're reeling them up too fast. You gotta bring them up slow.
You don't have to, just leave it, it's on camera. But, find one.
Usually you see it,
They're sick, fuck him.
Go to the class. So that's what happens when you reel up a fish too quick. This is typically seen, now, you're not gonna do it to a bluegill in 2 feet of water. Painful. But when you're dealing with, you know, deep sea fishing or deep water fishing, where you're dealing with depths of 50, 100, 200, 300, which if you're fishing 300 feet, you're gonna be reeling for a while. You just check your tank, so you're done with it. Anyways, when you're dealing with these 100-foot depths and you just start cranking it up and they come up too quick, what happens? All that gas expands because what's happening? They're coming from here and they change atmosphere so quick that that gas just goes. And it expands so quickly that now they have all this free radical gas in their bloodstream, which is going to potentially cause what? An embolism, right? Because that gas is erupted in there, and now you have these free pockets of air. That's the same thing that's happening to these fish, is all this air expansion that forces the air in their eyes out, and they have only one way to go. Now, you can sit there and chill on the deck a little bit if you want to be a good, they'll swim off of it, you know, they just got real good peripheral.
You can also fish the Ohio River and get very similar looking fish.
Yeah, that's because of chemical though. So, this is a little sidetrack, this Travis brought up a good point, but this is good, you know. It's important to know those things that, you know, you're going to have gas expansion, not only in increased elevation, but decreased elevation as well. So we went over partial pressures. Now, what does this mean? And what are we measuring there? Now, what is wrong with this value? Not to say what's wrong. What could potentially be wrong with this value? It doesn't take into account what it's saturated with. It just says we're saturated. So going back to your cyanide or going back to your broken oxidation phosphorylation case, it's not going to tell me whether there's hydrogen on those hemoglobin, whether there's iron on them, whether there is, well, it's not gonna be iron, so it's not gas in the mineral, but hydrogen, oxygen, whatever. It doesn't say what it's saturated with. It just says we are occupied. It says all 4 seats at that ride on that roller coaster are occupied. So that's what it's going to measure is, again, going back to your Hemi cell right here. You've got these 4 seats on here. All it's saying is 98% of these seats are occupied. 95% of these seats are occupied. Okay? That is what your saturation is going to give you. So what do we use when we're dealing with saturated values? Yeah, our pulse ox is how we're gonna get that reading. Now, if you use rainbow cables, we're gonna get SpO2, SCO2, SCO, and SPM, which is going to be your method. Those are going to do your array of gases in your body. Typical 2 that we only deal with obviously are SpO2, which is the primary one that we're going to use on most every patient. And then if you do fire rehab or you have some type of exposure, you might use your SpCO as well to see how much CO is in the bloodstream. Not saying that they're not good values, but I don't trust either of those. again, because of variability of what it's measuring. So when we're dealing with vent theory, we're going to be dealing with typically SaO2 and SpO2. So, stop the lecture. They're open up.
Or am I return?
It's in the,
That's desktop audio. Yeah, it's got audio right there.
Press.
everybody can feel it.
Okay. So anyway, we're gonna use SaO2. And what are those? Somebody come up here and write what those are on the board. Huh?
The value?
No, what they mean.
Oh. Both of them. Right, right?
What?
Right?
If you do it confidently wrong, you don't look as wrong.
Give me a confident in your ability to mess.
I've got the left. So SaO2 is going to be the amount of blood that's saturated. SpO2 is going to be the amount of hemoglobin that is saturated. So what does that mean for us?
One slightly less active.
There is a direct correlation between SaO2 and SpO2. One is looking at the blood as a whole, and the other is looking at a group of cells individually. But if this small group of the population is at 98%, what does that mean that the whole population is at? Likely 98%. Now, your SaO2 will never be lower than your SpO2. There can be about a 1% difference between the two. 1% to me doesn't mean anything. So to me, if I have SpO2 of this, that means my SaO2 in normal patients is going to be the same. Where do we have these variances? COPD, EQ mismatch, all of these things. And that's why it is extremely important if you have the ability, whether it's your point of care or reading values, to verify when you have an intubated patient, you decide to intubate a patient, or you have someone that you're questioning to intubate, to look at their SpO2 versus their SaO2 to see if those two correlate. If not, you have a huge VQ mismatch. And that is something that you as a provider must address or they will die. Okay? So other things that we're going to deal with in vent theory are going to be SvO2. Anybody know what that is? Oh, so close. Keep trying. Huh? Saturated venous blood. Now, the problem for us is the only accurate way to get this value. Anybody know how we get that value? It's a bird.
Fine.
Ah,
You said it's birds, it's fine.
Now, this is something we're never going to do in the field, not. Swan catheter is placed in the pulmonary artery, and it gives you venous blood gases at the pulmonary artery. Now, for some reason you take this transfer, this should be 60 to 80%. Going back to that, can anybody tell me why this is the higher end of what it is? Why that's our goal?
What it is.
I mean, yes, that reading should not be there on the arterial side. But how do we get to 80? We start with 100. Make sense? We survive off of atmospheric oxygen every day. Right? And what is atmospheric oxygen? 21%. Not, but 21%. That means that in a normal patient, if we're breathing in all this air, we stack oxygen, right? We make it available in our body. If we're surviving off of that, that means we should have a replenishment rate of around 80%. The problem is, people that we're intubating or on a vent aren't normal. Their values won't be. So these are the people, when this is put in, is when they've had a long-term DQ mismatch and they need to make sure that they're perfusing and oxygenating and ventilating. Again, this will be in transfer cases only. You're not doing this. Okay, but it's just one of those things. The last thing that there's going to be is the Anybody know what that is? Where might we get that reading? On the central line. Now, central lines are typically about 5% increase. If you're going to use a central over swan or something like that, so there's going to be a little bit of variability. But again, these are not things that you're going. Now, there are some services out there that do allow central line placement, but even if you do a central line placement, unless you have invasive pressure monitoring, you're still not going to be able to get this. This is going to again be off of those transferred patients. And the reason that we're going over this is because a majority of us at some point in our career are going to do transfers. It's how it is.
You said values are to be higher?
Central line values. Again, these are just values that you need to know in the case that you pick up a patient, you get to the hospital and it's a complete shit show with 9 drips hanging, vent is 10 ways of thought because, somebody with an IQ of 6 did the vent settings, and you have to understand, you're gonna have to identify, and I can say that a lot of my providers have run into that, where we get to the hospital and you've got patients that are Amanda's size with a VT of 750, and you go, excuse me, what? And again, we'll go over why that is completely wrong here in a couple hours. But identifying this, having these values, understanding these values and where to start allows you to know what is bad and how you need to fix. So any questions about this? We're gonna go over one more thing and we're gonna sorry.
That's good, my brain hurts.
Well, then let's take a break right now.
A little brain, a little absorption.
How long we got? 5, 10?
Let's do that.
No, after that.
Oh, dude.
Walk on, check it out.
if you're flying at 10,000 feet, you've got roughly 30, 60 seconds of time to address this is with the explosive. Right? You've got about 30 to 60 seconds to get on oxygen. And because, you know, if you go from the 10K to
Oh, you will.
yeah, but you go to 45,000 feet of
I mean, like overall.
big jet, you've got 5 to 8 seconds
And all that.
to get on oxygen.
So what I'm saying is, when you, even though you're cruising,
So you're going to have a 35 difference, that's going to give you about
They don't fucking shit those guys. Until then.
Reset it into.
I'm just curious if they Matthew. And I,
I'm okay with it.
yeah, so I know you're, go ahead and show all about it.
So, we're telling you how to raise part.
I'm the. Sure. So that's good. I would check that.
I came across, I was like. I would,
Check that. Yes. There aren't known. For that. They're like straight out in that. Units.
the CPR was. I go like, are they gonna be closer? She's like, I don't know. I was like, like, why aren't you all figuring this out? We, having to share. You know, they don't have to kind of. Well, then they
They
fucked
came up
up.
here the other day,
Radio said.
without this PR, and I was talking to them.
More Italian and stuff like that.
We are like it's.
What about the fucking fatality when I think?
They're like, we're just literally that person. And he was like, okay, 91, what? And he was like.
Because, well, that's.
Same old shit. They would have. Yeah.
It's never been good. I'm hardly anything like that.
Thanks, Taylor, told me that she's in the hiring process for Jeff.
Yesterday, that whole situation that went to. When I was like, oh, I can tell you.
Do you think
By the
they
end of it, I'm like, what are you? I'm sorry, I'm so.
I'm literally from 7. You know what Jeff Myers said? Fuck this one. They're not.
Well, that's good. I told him that when I
They don't want it. When they started, they stopped. Yeah, no, like, you know what they told me through the other night? Witnesses in the dead body. The captain of the truck shoot out one of the patrol. We don't do this anymore. Like, we don't do it either, man, but like,
Right.
we need to put this large dead person on this bed. And so he called fucking 4 cops to lift the dead body.
What I'm saying,
Because our fire department all
the North Transfer.
Who's the guy?
Jeff Fire, him, yeah, they don't do that anymore. That's what he, on body camera, watch it, it's on body camera, we don't do that anymore.
It's on 14, 15 copies of.
Instead of taking the 40 seconds it would have taken to lift, put on the sheet, look around the cop and left. He'd shoot out the cop, who's the patrol. I could call him. He's out after he need help. You're about 300 pounds. No. So, it wasn't the corner. It wasn't the corner. Fine. It wasn't the corner, because those motherfuckers are gonna start coming out for our dead bodies. I'm not sitting on dead body. I'm not sitting on it, like, so, our office is notorious not coming out to dead bodies. They won't come out. Right, oh, they're old, it's not all good, write down their name and pictures of it. I've been asked that too.
Same.
I've been asked that. I'm like, no, I'm not sending you pictures of dead body on my personal phone. I'm not doing that.
Oh, that's cool.
And, so now I guess we have a private company, it's not even a funeral home, that comes and gets the dead body.
I don't know.
It's shots. They said they were out here.
So
Ties.
that's.
I don't know.
They were
But
snarky.
did not know like. They had. The worst part about it was is. Oh, great. I'm like, yeah, the one that was in the top. You know, sleeping out. There.
So those sound like they're.
I think it's great.
So if you're.
And they, some of those heat returns. Let's talk about. It's like, we need your guys. Who else we gonna call? Shows up with a big truck full of fucking tools with the fucking 4 or 5 capable bodies. You know what I'm saying?
All
All they can do is fire on years. But like you also upgraded up the thing. And we need your. Look at you coming and swinging tall. God damn. It's a new lift fire. And this is like, we covered the fire engine covers the disc. Engine company. Hey, don't get back. I don't have to. Fireman. We start eating some. I don't know, man. They're like, what? That's what I was told by multiple of their probably level guys. Our company security. They goddamn. Low that cholesterol. They would talk.
You're gonna land this out with it. I can't wait to see what cereal lakes that with.
They're not. Shit. You know, whatever. They're good at fighting fire. So, I guess my house gets on fire. I'll let it go. We'll save the foundation. Fucking Sean, we saved my foundation.
Every community needs a basement safe.
Man. I don't know.
Hey, you're fuck up there. Okay.
We need a.
Alright, you're good.
But it just makes sense.
Between yours and your heart over there.
The corner's off. Yeah, that's. The,
Your EMS management fucked you, it wasn't your circuit.
well, yeah, EMS man, if you fire me, that's when you look at the. And then we're just sitting there,
You give it blood.
while we got court stacking and like all this fire parties and taking the medicine in our district and shit. We're just. We can't leave.
I'll just pull it out. Yeah, I'm fine.
Just when I was making headway, somebody drops off the form.
Appreciate you.
Only seen him come out.
All right. Couple terms that we need to know before we should all know what this is, right? Okay. And what is the normal hemoglobin value? Anybody know?
16.
15 is normal. Okay. It's normal values. That is going to be for total patients. Women are usually going to be a point or two higher or lower than men.
Mine's 11.9.
Yeah, like last time I went with blood, mine was like 8. Yeah. Again, we know each stands for what.
Fill on the last round.
I think I got a couple.
Stroke it in on
What you're saying.
That's a thing.
You have to take off. You.
Handicap.
Thank you. Okay, sounds painful.
Central,
Sorry, ADD moment. My bad. Happens occasionally. My apologies.
I have no idea. Honestly, a black fox.
Content of O2 on hemoglobin. Anybody know what those values should be?
96.
She's had a confidence in the phone.
Deciliter.
Deciliter. And so the hemoglobin is like grams per deciliter or globin per deciliter?
Up here?
Yeah.
Yeah.
So why are we measuring gases the same as we are measuring like?
This is an oxygen, this is hemoglobin.
Yeah.
That's a solute, just like sugar is.
Okay.
Like that's a mineral. Here, it's ml of O2 per deciliter. It's just the amount of volume. We're measuring ml of O2 per deciliter. This is not in a, but this is in a volume base, just like we do 15 liters per minute, right? We're just doing 16 to 22 milliliters of O2 per deciliter. And then the big kicker for us is going to be something called anybody tell me what that is?
I'd love to.
Now, what do we think that goes back to?
You should hold thinking about over here.
What thing you call?
It's possible we're just gonna.
Sounds like a
Let's do
fire.
that right. Fuck yeah.
That is your normal value for that. So when we're dealing with vent, we're trying to figure out essentially. Huh?
She was trying to see around you and.
Oh, my apologies.
Fine. You can see right there.
So the big thing that we're trying to do when we're dealing with vent or mechanical or non-invasive ventilation, or even, and please understand, this doesn't have to be an intubated patient. This could be a high flow nasal cannula. This can be CPAP. This can be Venturi. Because each time that we add like a Venturi or a simple mask or a high flow nasal cannula, what happens to that amount of concentrated oxygen? It keeps going up, right? To where we get to the point that we've got a non-rebreather or just 100%, oxygen, that we're going from 21% room air to 44% to 60%. All of those things keep elevating the amount of concentrated oxygen that's being delivered. So the big thing that we're going to measure. Let me tell you what that thing is possible. Very good guess, and you are correct. Amount of delivered oxygen. Now, do you know the formula and how we get that?
Is it delivered oxygen as in how much we are giving?
How much?
They give you-
Correct. So because that's going off of the fraction, how much oxygen is being used, okay?
Dead space. And
Sorry.
And what did we say Q was? And how do you think we get Q?
Both off?
Solve, right? Yes, we are solving for it. Anybody remember that formula? Does that help? Cardiac output, your Q, your perfusion, those are all synonymous. Okay? That is what we're measuring. Now, the problem here is, I know you guys have heard me say before, all breathers are cardiac and all cardiac are breathers and filtered other ones. This is why. Because what happens if I have no issue with my breathing, but I'm having some type of cardiogenic issue? What's going to happen? So you can have, so we're going to call everybody's baseline is going to be normal, meaning my heart rate's normal and all of that stuff. What happens when I get what happens when I get one of these patients?
I put the standard on the up or down.
Moving here, but not circulating oxygen.
You can be bringing in all the oxygen you want, but it's not going to be perfusing because either your heart rate is too low and or you've got vasodilation or whatever, right? You got vasodilation or something going on here, or you've got some type of hemorrhage and we're late stage. You've got these big vessels, they're opened up. So now the gas is no longer compacted because you have that vasodilation and you've got a heart rate of 40. Is that reaching the tissue at the right amount of time? Okay. At the flip side of that, you have a patient that's heart rate of 160. What's going to happen here?
It's not gonna be sitting there long enough to.
Correct. It's not having the amount of time to allow that gas exchange because it's just like, everybody ever watch TikTok and they see that dude do everything extra fucking fast, like comes in and fucking, that is what it's doing at a heart rate of 160. Yes.
I'm a guy the other night was a perfect example of that.
Yes. The one off Davis.
Yeah.
Having a cardiogenic issue, SpO2 was what?
87.
So had nothing wrong with his airway, had everything wrong with his heart. And that's one of those things that you have to be able to decide, how do I fix this? Is airway always the answer? The answer is no, it's not. It's the funnest way, but it is not always the answer. You need to sit here and identify what type of Q mismatch that you might be causing or the patient might be having before we just say, hey, let's do something with this airway. Because let's just say we take this patient that's going to have this Q mismatch and say, all right, we're gonna put them down, we're gonna intubate them, right? I'm gonna 100% FiO2 them, slam them with FiO2, and go through that whole process. Have I achieved anything? No, I'm taking this patient's airway away. I'm creating a greater VQ mismatch that is going to pretty much put them into metabolic acidosis, and I'm going to kill them. So you have to identify what is going on here. Now, with that, there are certain things that you've got to rule out when you're dealing with this VQ mismatch. And that's going to be your 3 H's. Can anybody tell me what those 3 H's are? Oh, okay, I'll do it. Your first one is going to be your obvious. Second one. Anybody know what the third is? Huh? These are the 3 H's you need to rule out when you're dealing with the VQ mismatch from the rib. And that should be very easy for you to identify. If their blood pressure, what is their SpO2 and their end tidal, what is their temperature? That is something that you can rule out in a literal matter of minutes. And it doesn't take that long. Now, why is, this one's pretty obvious, why is that bad?
Saturation.
Your saturation of oxygen is low, so even if you're doing well, there's no oxygen to utilize. What about our hypovolemia and hypotension? So once you get to a state of hypovolemia or hypotension, your body has the inability to cause vasoconstriction, right? So now we have these pressures that keep plummeting because our body can no longer vasoconstrict, which cannot get that blood or that oxygen or whatever to where it needs to be, capillary beds or alveolar capillary beds, to cause that gas exchange. And going back to oxidation, oxidation phosphorylation, what's going to happen? Right? What about this one? Break it down to a very simplistic level. What happens in your body? Just think, go back to just a very, I don't want to say archaic, but one of the most simple body responses to a fever. Your heart rate goes up. Because what's it trying to do? Move the blood faster to cool it off, right? Get it to the surface, cool me down, bring my temperature down. What's going to happen with this increased heart rate? Correct. So these are the 3 H's that you need to immediately correct. Now, when we're dealing with this part right here, what are the things that we want to consider? What are the things that we want to consider when we're dealing with stroke? Anybody know? 2 of them. Preload. Preload. The one nobody else ever gets. Good job. You can be late. Contractility. 3 things when we're dealing with stroke volume. So can anybody explain to me exactly what preload is? Whether it's in layman's terms or not a Google definition, but what is preload? Venous return. Huh? Venous return to the organ. Venous return. The preload is going to be the resistance of blood at the right ventricle. is going to be what we're doing and what it has to contract against. That is going to be the easiest terminology to understand, going back to tracing a drop of blood. That preload is the resistance at the right ventricle the heart has to contract against. So how would we fix this? If we have a low preload, what can we do? Real simple, two things. Fluids, pressors. Because if we're trying to increase that, we're going to do a volume response with volume replacement, or we're going to do pressors. Now, what is the problem with the first one? Take out Kool-Aid. What is the problem with the first one? Where do you typically see patients that have a preload issue? CHF. And what's the last thing that we want to do? Say, here, drown yourself even more, Johnny. Right? So you have to take care. You have to be aware of what patients you're dealing with. Okay? Now, what is afterload? Can anybody tell me that? Say that again.
The resistance of the left ventricle has to contract against.
It's the resistance of the left ventricle after the contraction, at diastole. So it's what is the pressure in the heart after that contraction has occurred and it's sitting against. Now, why is that important?
Because that has to be overcome.
Because that's going to inversely increase what? Your afterload is going to inversely increase
What did you say the definition of that was? Resistance of blood after what?
the resistance in the left ventricle for a contraction. So you have an increased afterload. That means inversely, you're going to have an increased diastolic blood pressure. That's where you're going to see one of two things. The first one is just going to be elevated pressures like normal. You're going to have 190 over 160, right? That's bad. But then what else are we going to have?
Narrowing pulse pressures?
Narrowing pulse pressures. Why is that dangerous? You're not moving blood efficiently, right? The closer those two numbers get together, the less movement there is. So think of your 120 over 80 of taking these big, giant steps, right, going through your veins. But then you do something, that's a 40-point spread. You get 150 over 125, now we're doing these steps. And it's taking longer for me to get there because the resistance on contraction and the resistance at rest are closer together, right? So it's taking a lot longer for that blood to move. So you're going to have negative perfusion because the blood's just not moving efficiently. Has nothing to do with oxygen carrying capabilities, has everything to do with how are we perfusing, okay? And then contractility, what is that? It's in the definition, it's how hard is it contracting? And what can we do to control that? Dobutamine is the best one. Most of us don't carry it, but that is the best one. Increased contractility. What can we do to make it contract hard? So those are the three things that we need to consider during afterload. Now, the second part of that formula is going to be confusing. Don't know what.
What is it?
If you get lost here, it's fine. But it is, I feel like it's important. So we've addressed the left half of the formula, right? We've addressed this. Now we need to address this. Now, what is that? Good. We can read. We haven't lost all hope. We can read. The content of oxygen in our hemoglobin on the arterials. Now, even at point of care, it's very difficult for point of care to get this value. Okay. However, I like math. And then who just broke? So to get this, we're gonna cross over our line here. And this is how you can get this. I leave myself enough room. So I'm going to tell you, this is the actual formula. However, if you actually want to do this in the field, let's do this. I don't need that part. Anything times 0.0003 is a really small fucking number. It's not going to make a difference. Okay, so this is what we're going to be working on. Now, what? Okay. So this is a given. Okay, that is a standard number. These two change. Again, you're going to need point of care to get these values, at least the hemoglobin, right? Going to have a lab value to do that. There's no way to guesstimate hemoglobin. I guess you could have you had your blood drawn recently, and if so, positive, but barring that they had any type of traumatic injury or volume, that's going to change. So, I will say, like I said, the secondary part of that formula is obsolete. It's not going to change your values enough to give two shits about. What we need to do is, again, going back to this. How do we get that back? What is there a direct correlation with on that? SaO2, SaO2 and SpO2 have a direct correlation, right? So what we can do is we can take this and do our formula. Say, what is the average hemoglobin? Well, it will end up in the center. Somebody do the math. Yeah. We'll just say it's 98. Good. So, what do we do with that number? Nothing. That is our value. Okay. So we've got 18. Is that what you said? So what we need to know is that when we're dealing with this, 0.15 to 0.3 is the ideal value per kilogram. It's the ideal value that we're working with. So let's say that this patient is 186 pounds. Do our math. Give me my high and my low level.
Patient running 7.9.
So how many keys is this? So what's 84 times 0.15? And double that is going to be what? And my value was what? Between that threshold, I am perfect. Now, here's the problem, right? Let's say, again, let's take breathers out of it. You know, breathers have a problem, right? Let's take a car accident that we've got either a positive fast on through ultrasound or we've got grave abdominal distension, right? And we do a point of care, and now this value, they now have a hemoglobin of 6. What does that do to this value right here? That changes this to what? Huh? That between my threshold? Fucking problem. So what do? One of 3 things. Fluids, but that's going to help the pressure, but what is it not going to help? Oxygen carrying capabilities. But if we're hypotensive, we can at least cause some vasoconstriction to make that pressure better to get it moving along. The other 2 things, packed red blood cells and whole blood. It's your other options. Lots of it.
Would plasma light help since it has like some
So,
capabilities?
and this is going back to plasma. So, plasma light in and of itself does not have oxygen carrying capabilities. What it does is it helps alter the oxidation phosphorylation clause, or that process, that's going to free up some of that free radical hydrogen, absorb that, and allow the binding to oxygen, or the hemoglobin for oxygen to be better.
So it would be bad in this case if we don't have hemoglobin to bind to that hydrogen.
Plasma light would be good because it's gonna absorb that hydrogen and leave those seats at the table available for oxygen. So that's why plasma light can be a good substitute, is plasma light in and of itself does not carry oxygen. It's not just some dude in there just attaching. There's no molecule that's going to do that besides hemoglobin. But what it does help it absorb some of the trash that is in your bloodstream to free up the hemoglobin to carry oxygen. Because again, hydrogen has a greater affinity, 200 times more. So if something else can absorb that, brings down that lactic acid, brings down that acidosis, and frees up the hemoglobin to allow that carrying capability. So this is extremely important when we're considering this trauma situation. This is only, I won't say it's only important, this is mainly important when we're dealing with either anemic patients or trauma. We need to know what our perfusion is, or what at least the content of our hemoglobin is, to know, again, do we need to make an airway adjustment because we're having a blood issue. It's not ideal, but sometimes we don't carry packed red blood cells and we don't carry whole blood. What is the alternative to change this value? This is the only thing that we can adjust it. Now, if they're sitting at 100%, we're 2 ways of thought, right? But they're not. Because this whole process here where this is adjusted is causing a lot more trash, right? So whilst they might be occupied, we don't know what it's occupied by. This is the only value that we can adjust. Now, again, going back to either other formulas or point of care testing, we can verify what our CO2 and all that is internally, and later when I'm gonna have lunch, you're gonna have one thing of homework. And that's to look up that, term right there. That's not just the word beef. Google BE and the correspondence to that.
Is it also a byproduct?
No.
Okay.
So any questions on any of this? So, if you guys want a copy of my notes, I can hand them out. Again, there's gonna be a lot that doesn't mean don't write your own because half of this you're not gonna understand. So, but in my notes, I've got a chart. I'm gonna write down like 4 different points on here. So, and the reason that this is important is because now going back to the hemoglobin issue, if we have low hemoglobin, that helps with the oxygen and helps with the hydrogen. See that issue, where else are we going to see a huge change? Why? You sit over there and just like move the mouse, play this, that thing. Why are we having a pH change? We're not having the conversion of absorbing the hydrogen, we're not blowing off as much CO2. We're having that, the blood, the hemoglobin, the hematocrit, the hemoglobin are all dropping, meaning my oxygen carrying capabilities are less, meaning my C2, the CO2 carrying capabilities are less, meaning my hydrogen carrying capabilities are less, meaning I'm going to have a huge increase in what? Thank you. So when we're dealing with, let's say, we did our PO2, we're doing with a PaO2 of 15, I'm gonna have to copy this note, I don't remember this. So when we're dealing with that, you can figure that your pH is somewhere around 7.6. Little high, not great, but another value, pH, and then H. What is this? Bicarb, right? So that means that the bicarb level should be somewhere around 15 to 20. Now, is this a good value here? And that's why this is going down. We're becoming more what? Alkaline, right? So now let's jump up to, let's say, 30. At 30, we're going to see that good? Not horrible, right? It's doable. I'll take it. Let's go to 50. Well, how's that? Borderline, right? And what lies dead nuts down here? That puts my pH between this value and that value. That makes sense? Because our normal end title that we want to see is what? Now, let's go all the way up to here. So you can see how end title in and of itself changes your pH. And that is only going to be exacerbated when you have less carrying capabilities from blood. Good? Right, keep going.
If you've ever seen a bag of KFC mashed potatoes, that's what my brain feels like. dry, lumpy, mashed. No gravy at all.
So we briefly touched on the DO2, which is what? Okay, and we went over earlier our O2 ER, not the amount of O2 available in the ER. An extraction ratio. Why is that important to us? Mhm.
Is it what you pulled for you?
It shows what value we're dependent on. Does that make sense? So if we take formula for this. It's MC. I guess I can write this. That makes sense. Now, again, how do we get our CaO2? Based off of our hemoglobin and our SpO2. Usually we're gonna have that value when we're dealing with related patients, right? Ideal should be somewhere between 4 to. And how do we get our CdO2? Oxygen saturation, right? And what is that normal value? 70 to 80, okay? So again, we need lab values for both of these, but the reason this is important is because of the VQ mismatch. We are working our way to understand all potential problems with the VQ mismatch. So what we get, so our C, let's put this in a normal formula. This should be somewhere around what? Give me a value. 95, perfect, thank you. 95%. And our data should be somewhere between 70 and 80, so we'll use what? All over what?
So, back corner, I go downtown.
So with this, what does that mean? What do we do here? To put this in actual numbers, 0.95 minus 0.75, all divided by 0.95. Someone do that math. I bet you're gonna come up with a very familiar number or something really fucking close to it. Point what? Also known as what? And what is our atmospheric concentration of oxygen? Crazy. Right? So, this is important, understanding how much extraction of oxygen you're going to need in your patient. Beyond that, this is not important. So, so I know we said earlier, when we're talking about that DO2 that we just did that whole formula for. Remember what I said? Whole DO2.
0.17 to 0.3?
Huh?
Your DO2?
DO2, the total. 0.15 to 0.3. Right. That's getting there, but the actual this value here should be somewhere around 900 to 1100, right? Now, the thing is, that is including everything. That is total dead space, that is lung capacity, that is pulmonary tree space, all of it. That is everything of your body's different things. The thing that you have to consider is, are we perfusing at every millimeter of our body every time? What
People have poor heating.
They do.
Would it be as an example of like if you're exercising in the and then
Yes. Right, and that has to do with surface area, because the more surface area you have, the more oxygen demand that there's going to be, right? So when you're dealing with this, you have to understand that, I guess the best way. The only thing that I can equate this to is finance. So when you're done dealing, like, we're dealing with DO2, we have to be based off of DO2, right? It's just gonna be your volume of oxygen that's coming in, your volume of oxygen that's being inhaled. So what we're wanting to do is, I'm just gonna do this in finance terms. So when you're dealing with finance, has anybody ever bought a house and a car? Everybody else has just gifted a house and a car?
oh no, I'm
Okay, so when you sit down with a finance manager or finance person, they're gonna sit here and they're gonna do this whole thing where they say, hey, you got all these things, right? The reason that your interest rate is so high is because you have an issue with DTI, which is known as what? Debt to income, okay? Debt to income. Now, consider this is our income, right? That is every possible amount that could come in, right? But what we have to do is consider that we have a surface area, and they use, I think it's 1.7 meters squared per surface area, doesn't matter. But by the time that we consider all the dead space and all of these things, on all of this VO2, we are actually producing about half, which would put this somewhere around the 550 ml mark. So this is the value that we're going to use, okay? So when we're dealing with that 550 value, we have to consider what are we breathing in and at what percent, okay? So if we're dealing with debt to income, right? We have, like, this is in the presence of FiO2. So if we have someone on no increased FiO2, what is our FiO2 percent? 21%, right? And just to make it easy on my brain, I'm gonna do 20%. Okay? So if I take this 550 and I multiply it by my 20%, what do I get? 110, right? Now what do I do with this 110 value?
Let me get, oh, never mind. I see the 550 and $10.
This is what's actually being delivered is about.
So in like finance terms, how famous truck?
This, no, in this, in finance terms, this is gross, but this is net. Fuck the government, right? This is net. Okay? So out of my net, this is what I'll be bringing home. Okay? This is the payment. This is your house, this is all your debts combined. Okay? So you're at 20%. 20% of 550 is going to be what? 110. Now what do we do with that value? So this means I need 110 ml of oxygen to perfuse my body. Is that a lot? That was 110, right? So what does that mean for us? So 440 reserve, is that good? Fuck yeah, it is. I'll take that DTI all day. That means I breathe in 550. I only use 110 and all that other oxygen is just chilling in my body. That means I can sit here and not breathe for 4 to 5 minutes and I'm good, right? That's a good debt to income. But the problem is is if I'm going to increase this to here, now what? What's that? Should be right.
Yes.
That means now my reserve is what? Is that a good reserve? No. Now my reserve is only 20%. And that means my debt to income is real bad. That means I can't afford it. So these are all things that we need to consider when we're talking about family. Now we're gonna start getting in the meat and potatoes, so let's, yes, Sterling, this was not the meat and potato. This was just that. So, and then we'll.
I got too many fucking bad.
Yeah, Dave. So you're not Dave.
But he erased it.
So, this one we're gonna use. That's your issue with all this. I'll do that. Either personally, and Scott, he won't be here.
I got that in the violence.
And then I think this one's not in there. Can't find it anywhere. And then you still need to document. Male, female, like lab draw or ID or whatever. So sign all those, the ones that you can, and give back and approve those. But yeah, that's your main thing, is if you're not getting the preceptor or you're not signing it. That one.
Need a drink?
I'm right there. That one was really down the line. And then back. One, that's fine, you're good. No.
Yeah. I just want to say that, like, I'm tracking, and he's gonna say one thing, and it's all just gonna go.
Isn't telematics also?
Not this for your class. My respiratory class.
Trevor, everything got PC fire. PC, flight cert fire.
Oh, yeah,
All that.
I'm just. Yep. Well, get your little Mariposa Pro jacket on.
It's all right.
Got pockets. Got pockets.
Got it, so box, check it.
Probably put your keys when you drive.
Just wear it in here because it's cold.
70 something here earlier. You can turn that on, even operators come in here.
T-shirt. HR got me again.
Really? I think, a couple years got returned. No, I figured it Amsterdam it did.
Fucking microphone.
So under your preceptor, like on your platinum, you have Nick as your preceptor, and it's nurses from the facility. There's that.
But it's a drop down box. Is it let's type it?
You're the only one that has ever done. Everybody else has been done. It's a user issue.
That's fair.
Preceptor.
Don't worry about that.
Yeah, alright, I'll update it then. The only one that you should not have, you should.
The merit one, and the one.
Okay. It's not cold.
My hands felt too doing good.
I don't know if it's cold. I don't know.
Nigel, you're asking to beat one time being back. And they get to beat constantly on my truck. What the heck?
Well, no, they finally got from all right in here, so you probably won't hear me deep. But I would fix it, it's still early.
Oh, so. You did something. I'm having a hard time with it. Yeah.
Your. Giving you a call. Information.
I lately keep being brought in and
This quote, if you could,
I'll come back tomorrow and it's gonna be very.
Backward and seeing the results. I didn't pay anything.
Yeah. Trevor's inability to get along with others is what got him.
Oh, my inability to get along with others is how successful I can raise anarchy.
How successful what?
I can raise anarchy. Not my attitude, or the same attitude.
It's just,
I agree with the enemy to raise people. That's it. Cause reading through this, I was like, you know, there. Now it's like,
go back and read all this crap.
What is it? How does it go? If you don't mind. Better call something. Oh, I can't. She walked 6 inches and you had to walk 30 feet.
I knew 30 minutes. I was like, all the time. And you're like, this. Jackie got in front of the mine.
Oh my God.
That's funded.
Okay, that's gonna charge you $1.
Does anybody need some ibuprofen?
Yeah.
Yes.
Jackie, just act like it's a party. Just walk down and just pour it out on the table.
Little funny. I like it.
you got the flyer, he's been there 100 times already this year. Yeah. Yeah. Wouldn't believe. I think he just finally hit his time.
Andy, like me.
And then I won't get it again.
I know I can't.
My God, I have a problem more.
All of it, gonna get the sandwich and go to
That's bad.
Ron, your favorite dessert?
We're gonna send you this.
That's where we would wish our county could make up.
Whether it's right or wrong.
They do that.
But they just
Time of the year. That would-
They didn't tell us.
Not saying that they we tried to. He wants that sandwich and they can't deny.
What?
Yeah, you can't include it. There's not.
I'm mine.
If we drop them off.
Mine?
They would.
I thought. Like, makes it pay cash money or the pay rate, something I haven't seen how.
Yeah, I work 100% all the time.
Yeah, you see, it doesn't, I think we need to change our LP contract. It says, we're giving you salary, we get a tip in the city. Yeah, man,
He loved Jackson. We followed him to other. But they were getting tired of seeing them, so they wanted to send him out to the waiting room, make him sit. 2 or 3 hours and then bring him.
Thank you, Tyler.
That's why he came back over here because we could, they have to go straight to the. Unless it's. Yeah.
Your brain needs that, don't it?
You already know. He came down here for maybe a year. And he's one of our.
Did we ever go over the VIO list? Okay.
Do it.
Oh, never one count.
Your name 3 times and you should call.
I'll get it.
I'm talking about Pam.
Yeah.
Pam.
Somebody said it twice, and then I was like, can we not say it one more time?
Yeah, I came out.
It was like an hour.
Maybe we'll have.
I'm sorry about that. I haven't spoken yet.
I could.
Yeah, you said focus.
You know, if you breathe.
I forgot to. And after she realized that she was being offended, then.
All right, so going back to the last thing that we went over, that target that we're looking for, at, O2 ER is going to be between 20 and 30% is the value that we're looking for. So when we do that math, ideally, we should be between 20 and 30%, or 0.2 to 0.3, right? Anything after 0.3 or more than 30%, so once we start getting up into that 30, 35, 40% range, intervention is imminent, meaning we have to take control. There's no way around it. Anything beyond 40 is probably imminent death.
What value is this?
Your O2 ER. So when you take your SpO2, if you will, and subtract, or your SpO2 and subtract it from, your CaO2, subtract it from your SpO2, and you do that, where we got that 0.21%, we get to above 30%, or 0.21 or 21%. After we get above 30, intervention is imminent. There's no way around it. Don't need to do more mass model index or anything. So going back, so we went over oxidation phosphorylation, right? Or oxidative phosphorylation. That was dealing with what type of respiration?
Aerobic.
Aerobic. So we have oxygen. Now, something we need to consider is anaerobic respiration. Okay? Will we have oxidative phosphorylation with anaerobic respiration? No. There will be no oxidative phosphorylation because we don't have that oxygenation, right? We're doing it anaerobically without oxygen. So when we're dealing with anaerobic respiration, we said we have a net of how many ATP?
36.
36. We have a gross of 38, net loss of 2, so that's a gross of 36 total, right? A net of 36 total. When we're dealing with anaerobic respiration, what will we have? How many ATP will we have?
0, 2.
2. So what does that mean? So when we're dealing with this whole process, right? Anaerobic. It'll be 38 growth, 2 loss for a net of 36, right? So that means we have a lot of what? Energy. This being heard, right? Because in order for us to create this many ATP, we're going to have to create this. Now, stepping back a little bit. Should be right there. There it is. Yes, right. Okay, so with aerobic, one complete cycle with 2 pyruvate strengths, so 1 crank cycle, is going to cause this outcome. Completion of the actual crab.
Blood transfer, downtown.
Okay, so that's what we're going to end up with, right? So that means, essentially, for in real layman's terms, but just to grasp the picture of this, we're occupying how many hydrogen?
That's pretty.
8. Okay. Again, not true, but just for layman's terms, visual purposes, we've got 6 NADH being produced and 2 FADH, right? So 6 plus 2 is 8, right? So we're occupying 8 of those hydrogen from this process. But on anaerobic, this part is not taking place, right? So what's happening to that hydrogen? It goes into where? The blood. And what is that going to cause? There you go. It's going to cause very quick acidosis, okay? Because the hydrogen, again, has the higher affinity to the hemoglobin, right? And even if some of that doesn't permeate through the membrane, what is happening inside that cell? The hydrogen is going to build up in that cell, causing what? Cell death, because it's going to become acidotic to the point that everything shuts down. So now all of these cells that are going to be producing these ATP, even though you're doing this, are starting to die. Now, this is your aerobic. With anaerobic, we said it does how many ATP? 2. Pretty big difference, isn't it? So what does that mean?
You're gonna lose your ATP a lot faster. So you're not gonna have.
The lack of ATP production is going to cause your patient's ability to maintain to be non-existent. Once you get into that anaerobic cellular respiration, this is your decompensative shock. Like you cannot do anything anymore. Your body is in extreme survival mode, and everything is just doing what the fuck it wants to do. Your body cannot maintain without ATP. Okay, so again, we have to consider what we can do to help. So there's a couple of different, just understand hypoxia. You can get into the different hypoxias where we're not going to get into. There's the hypoxic hypoxia, There's the hypermimic hypoxia and there's stagnant hypoxia. If you want to know what those mean, look them up. But we don't need to get in that and quantify today's class. We get further on here. But just understanding there's different forms of hypoxia that can be triggered to decipher what you need to do. Any questions on that part? That once we're in that anaerobic cellular respiration, like we have to intervene or get this. Because it's not necessarily, there's two reasons behind it. One is because the increased what? Hydrogen is going to cause some form of sepsis or cellular death, one of the two. Or what?
Increased ATP production.
ATP production, which is going to kill their energy reserves. And then the third one is just going to be the low oxygenation because they can no longer maintain themselves. So invasive oxygenation is going to have to take place to increase these levels back up. So we talked about end-tidal CO2 and we talked about how PaCO2 and end-tidal are going to be similar, right? We all should know what hypercapnia is, right? What is that? When your end-tidal CO2 is above 45. Then you have hypocapnia, which is when it's what? When do you typically see your higher than 45 patients as a normal relative state? What type of patients? COPD and asthma patients, right? Hypocapnia can be when? Hyperventilation, or even having all that stuff. So we have to understand when we start innovating these patients, the biggest thing that I can tell you in layman's terms is don't fucking chase numbers. Now, you have an ideal set of goals, but do not chase numbers, or do not chase a singular. Be a bigger thing to say. So if I know, that we've got these patients and they've got COPD and asthma, am I going to want to achieve a 35 to 45 entitle? No. So don't chase numerical values. Understand what that normal is, but you have to understand that normal is relative. Your patient's normal is also. And those two may not be coefficient of factor. Meaning, just because 35 to 45 is our normal entitle range, doesn't, that's where our patient needs to lie. We might be okay at 55. So don't try to achieve relative normals when we're doing these patients, especially with innovation. Because again, we can start that nitrogen washout of these things. And why? So now we've learned some stuff about nitrogen and gas. Why do we think nitrogen washout is bad? Thinking about the molecular size of nitrogen, thinking about how much nitrogen is in air. Why is nitrogen a washout?
And you know how it's active within
Specifically where? The alveoli. So if we cause this displacement of nitrogen, we're going to end up with collapsed alveoli and atelectasis. And what can't we do if that happens? Fuse. Because all of those sacs start to collapse because those big gases are not keeping them inflated. And on these smaller molecules of oxygen to keep them inflated, you'll get alveolar collapse, which is going to cause lack of oxygenation. So you're going to have huge, it'll be one of the main BQ mismatches, huge readings on your SpO2 because your concentration is through the roof, but you're not having that diffusion. So when we're dealing with end-tidal, specifically low end-tidal, we should know how to correct higher. The main thing that we need to correct, or we need to understand how to correct, is low end. So there's this 3P rule of low end. Anybody have an idea what they are? Like things we need to check. 3Ps that we might. Title C2. Great. Pulse, good. DOS we have. If so, what? Again, going back to that bradycardia tachycardia. Is that value good for sustaining life? Pulse, but it's 40, is that going to do anything? If I have a pulse, but it's 240, is that gonna do anything? Right, so we need to know, A, do they have a pulse? That's a good start, if they don't, this just fucking changes the game, right? Makes it pretty simple what we need to do. And if they do, what is it, and do I need to correct it? Second thing would be what? Perfusion, particularly perfusion. Perfusion status, what is that?
Oh, well,
Thank you. How do I get that?
In color.
What did you say?
In color.
What's a normal map? What's a perfusible map?
160.
That's our ideal map. Greater than 65, less than 110. Because after 110, we're gonna start having vessels and stuff in our brain and alveoli. And anything less than that, we're just not achieving enough to perfuse. So again, going back to these low enzyme locations, they might not have an airway problem. This might go back to our 3 H's that we talked about earlier. If I have a patient that's 72 over 40, what is my map?
I don't know.
We should know our map. I've given you this formula like 5 times over back on that board. How do we get a map? 2 times diastolic plus systolic divided by 3? That sound right?
Whatever he gets.
Times diastolic plus systolic divided by. So what is my map? So 2 times 40 is 80, plus 72 is 152.
540 is map.
No shot.
Good try there, Charlie.
50.04. 05.
So you can't just do 72 plus 40 divided
That
by
was an
2.
awesome thing I've ever seen.
Mean to your pressure. It's got to be 2. That should equal 50.5, right? 50.3? 6.
I'm at full meeting. More than 15 plus 60.
So this is gonna give me a map of 50. Is that good?
Hey.
Is there a struggle busting over here?
Fucking drive. Let's fucking drink.
Hey,
How about that?
so my map is 50. Do I need to address airway right now? I need to assist with it, but is that my main fucking avenue of treating this patient? No. Because even now, can you have a ventilation issue? Can you have a ventilation issue and a perfusion issue? Absolutely. But if we're only getting certain reading, if I have a low, if my entitle and my map is low, do I need to immediately address Airway? You give supportive efforts through Airway, but that does not need to be my first plan of attack. I need to get that map up.
It could be a ventilation issue, right?
It could be a perfusion issue. Whether now, the only other caveat is could be something that is obstructed. Now, what would be obstructed? FPE, cardiac tamponade, increased thoracic cavity pressure, any of those things that are not allowing your heart to expand and contract fully. So then what do we do? Full send to Jesus, okay? Simple thoracotomy, chest tubes, needle decompression, whatever you need to do to bleed off that pressure. Most of us cannot do pericardiocentesis in the field, and I should not wish that upon any of you. But sometimes when you're in tamponade, that is the only thing that you can do to correct that. But you have to understand what is going on with my patient, because if I have something obstructed, I need to fix it. Because that is going to cause both of these things to decline. So that's what I'm saying. There is one caveat in which I'm going to attach the airway first. May not need innovation, or it may need innovation, or it may need innovation with conjunction with thoracotomy or something like that. You need to address it. Because if we simply just innovate this patient, right, and we have increased thoracic cavity pressure, what are we doing? Making it worse. Which is going to cause us to go into heart failure and just get quicker. They're going to go, no, mom. And now you really, okay?
Stabilize.
Now have stable rhythm. Now, what is the other P? When in
I confidently said 104 and got it wrong, so I don't know. Word.
when in what? And what do we deal with when we're talking about Rome?
pH.
pH.
Respiratory. He done crossed the ocean.
See this Roman Empire we built over here.
Yeah. I'll plug the brain mouth thing back.
This is when you're partially compensating for metabolic acidosis, right? You're going to get pH readings that are showing we are compensating by our breathing with metabolic acidosis. Go back to your Rome chart for check reference. If you're having a decreased pH and a decreased respiratory rate, or increased pH and decreased respiratory rate and a decreased end-tidal CO2, what do we have? We have metabolic acidosis, right? So if we transition from that respiratory issue to that metabolic issue, that needs corrected. Because what's happened? Our kidneys can't keep up at that point, right? Our kidneys aren't filtering, our liver's not filtering, so what is going to happen? Our lungs are going to try to take over. We have to do that for them before they come decompensated, okay? That's the one thing that you need to check, is make sure that even if you don't have point of care, even if you don't have the ability to sit here and go, my pH is 7.1, right? That thing that I showed you earlier with those end titles and those charts shows you where that pH should be lying with those end titles. So if you can remember that, simply use Rome. I know what it should be if it's respiratory. What is it doing when it's metabolic? And if that's the issue, we, as the provider, need to correct that. Okay? Any questions about any of that I can clarify? Nothing? But please do not chase number value. We want to be in the ballpark, don't get me wrong. But don't take your COPD patient down to 35. You're going to make it worse. You have to understand those are relative to normal. One other big brain's probably going to fry your brain really hard till we get into the ventilation side. So we can do one of two things here. We can do a little Q&A, answer questions what we've gone over for the next 20 minutes, or we go to lunch early. Because I don't want to get into this now, because I'm going to need more than that.
I don't even know what questions.
The question is, I know,
The human head weighs 8 pounds.
I think I weigh more than that.
I'm
I
with
got
you.
ideas. I was gonna say, measure washout causing that, alveolar collapse. How do we fix that? I was assuming pressure, but if they're already, you just give them oxygen, the pressure is oxygen? Or
So oxygen, if you have a nitrogen washout, oxygen is not the issue, because what do you have the majority of it? Pressure is the issue. So when we get into mechanical ventilation, we're gonna get into volume and P flat and mechanical pressure and hit, okay? So, and that's what we're gonna go to the second half, is when we're dealing with P flat or PIP or P pressures, dealing with mechanical ventilation, that's when you're gonna have to start adjusting your P flat or your PIP.
Will we also go over like basically signs and symptoms of anaerobic like oxygenation or respiration? Because I know you said like once they get to that anaerobic part, is there any way that we can tell? Just their own.
No, not just all of this.
So when we talk about nitrogen washout,
Throw the question.
yeah, my brain immediately went to heat. This is further ahead. Is it just an increase in heat or not?
I went to see.
It's not just an increase in P. It's the disassociation between your P flat and your PEEP, or your PIP and your PEEP.
I know these are so close.
Did it back after that.
They go back to that 6 up the pages here.
I also have 2, 3, 4, 5.
But we're only do like one of those.
I also understand that. Guess we could probably go over this real quick. Well, if it sucks, then we need to answer some questions. No way that none of you are all sitting here. But I understand you may not know what to ask, but then we need to figure out what you're not understanding. Because this is highly important.
I feel like I understand it, but I know there's gonna be a moment, you say one or two things, and I'm gonna be like, oh, I don't understand. My brain's like, oh, yeah, no, I need to.
I understand like 5. I was trying to understand our capital. 5, I need to understand how that plays into that. If this, I don't know when like I need to calculate my O2 ER and apply that to what I'm doing. And that little I feel like
or
it's
when,
not meant to make an impulse.
your O2ER is going to be, when do I need to intervene with possible? So again, when we're doing this, you know, you're using your normal minus what it is, right? So, if you're taking 98%, and the patient's SpO2 is 70, do that equation. And it's the minus, right? With the, just do 0.98 minus 0.7 equals divided by 0.98. So
0.28, which is in.
So that equals what? 28%, right? At 30, we have to intervene.
Not getting on the edge.
That's what that's good for. Meaning, is this sitting in the realm of possibility that we can just correct this with a using cannula or some past spots? This is that formula, that O2ER, is where are we transitioning from passive oxygenation into invasive oxygenation?
And that's something that is.
And I would say invasive, like some of it can be non-invasive, typically with your bi-level oxygenation with BiPAP or CPAP, right? But we're taking away from that passive oxygenation of the nasal cannula, non-rebreather or whatever, into that typically BiPAP at our level now, right? Or CPAP, if you don't understand BiPAP or your bed can't do it, or possibly intubation. But after 30%, means something in that non-invasive / invasive.
Is this something like, after the truck, you're doing this in your head, or is it more or less you just understand, hey, when I start to see these things, I know I'm training this way?
It's a combination of both. I mean, I do the math in my head real quick.
And then like the SpO2, SCO2, like that's more like pressure stuff, right? That's more like our blood gas levels.
Yeah, it's ABGs and lab. But remember, there's a direct correlation between SaO2 and SpO2. Because SpO2 is a small snapshot.
Sure, I can do it. I can unavailable.
That's where I'm getting different, like CO2, SPO2.
And that's why I said, your homework, we needed to do that just to get familiar with what these are and what these are.
Going over this now, I think I can do my homework a lot better, kind of understanding, so I think I wanna like, really,
You're gonna be,
Yeah.
I'm making a chart of
oh,
like,
you'll be doing your homework.
oh, well. I was anyways,
Figured, yeah.
I was gonna
Figured
go
more
for it.
like a note card thing, and just keep doing it.
Yeah, so you did note card or what are these, now you'll be doing.
I'm barely forming a sentence.
What else do we have?
So it's going like on the alveolar collapse and everything like that, with nitrogen oxide, with the nitrogen. I know you said oxygen wasn't, so if we just like completely disregard BiPAP or CPAP.
No, because that's pressure. So what I'm saying is, if you have that, just increasing FiO2 in and of itself. Increase level. Nomenclature you would use it, that's already increased, push the oxygen for the nitrogen out. The oxygen's not the issue. Right. So doing passive oxygenation, the hypotenuse and the non-breather, that's whatever, it's not gonna solve the problem. And then perhaps you need something to inflate those alveoli. The only thing that's going to do that,
So what's gonna cause,
it could be a number of things. It could be that your FiO2 is too high. Contrary to popular belief, it's not high flow O2. Understanding FiO2 is extremely. And we'll get into that towards the end, I believe. I got it in here. Yeah, halfway through of FiO2, understanding those values. But yeah, I mean, understanding where you need to be. We're gonna use my Hamilton vent. So Hamilton. So who have? I know you guys have Zoll. Who else has something? Anybody have Rebecca? You have AHPs. That what you have over there?
We have.
Those?
BBN.
Good old hand.
Unless we get them from the hospital, then we got trilogy.
The home vents? That thing's gotta beat more than you do.
If we can take a patient out, we don't have to do anything else to do with BBN.
What do you guys have down there?
Can't drive, I'm subject to bullying myself. It's maybe like I should.
What?
No, I'm not saying it, I'm just subject.
I will tell you how much we innovate.
Probably none, because you're bound there. The,
Well, I wouldn't go
not
that
very
far.
6 people out here.
Far, but
It's because you preload your weed.
That's the video, I was like,
I want to hear this thing.
Tyler, you freeloading your
whatever, but I don't.
Preloading the training room for you.
we got subjected to like, we don't got it, we can't do it. Pretty
the
good.
jelly on it.
What's the difference between being preloaded on there and then just straight?
Well, so- And we don't want to. So.
Hey, how about?
How about this, judging?
Oh.
Anything with the door open?
No. So it's my base. Like, I love it. I don't know if you can tell. But pressure is superior 99% of the time. Now, unfortunately, your Rebel, Soul are volume only. Now, it doesn't mean they can't operate on pressure, but the primary function is volume. And it gives volume to achieve a pressure. Okay? The reason that pressure is superior, in my opinion, is because there's so much fluctuation with volume. So with your Zols, which Rebel are amazing bits, but their volume as well. Oh, however, I really do like it. But your Zols and your Rebels, you're dealing with need to achieve X amount of volume to achieve X amount of pressure, right? So it's dependent on delivering a certain amount of volume regardless of the pressure. And that's where it gets dangerous. Because if I have a volume vent and this thing, volume vent, we're pushing out a certain amount of volume. So let's say, I'm gonna hand these out once we get into this part. Let's say that I need my ideal body type of volume is going to be 500. What it's saying is on a volume vent, I'm pushing 570 ml of air on each breath, right? But we can set a pressure limit, but that doesn't, that's T-flat, which we'll get into. It's saying that that T-flat is there, but now we have a mismatch with our DTEs, which are our minute volume, of saying, okay, I can't reach with this volume because I'm hitting my P-flat. So now what do? Now my VTEs are down, right? Our minute volume's down. With pressure, we say, we don't care. We're gonna look at pressure and our VTEs and that's it. We don't care about what our tidal volume is. Because we know if we're staying at or under this pressure, and we're achieving this VTE, my oxygenation is fine, right? I'm not dependent on delivering 550 ml per breath, right? I can say, as long as my lung capacity reaches this pressure, which is a perfusible pressure, because that's what we care about, and my VTEs are in this threshold, which I'll teach you how to get there, don't care what my tidal volume is. As long as my minute volume, my pressures are good, my tidal volume has to be. And that's where pressure and volume start to differentiate, is volume is so dependent on volume. You can get real dangerous with that, because if you don't catch your P-plat to peak disassociation, you can pop a lung like that. If you forget to set your P-plat, or your P-plat limits are too high, or your P-plat to PEEP are too differentiated, you can start causing huge oxygenation issues. You can actually cause more VQ mismatch with vent or with volume vents than you can with pressure. So that's why, I'm not saying they're a bad product, they are good for what they do. I just prefer pressure volume vents over volume vents. Because that is primarily pressure, but you can do volume. We'll go into those. We'll go to SIMV, PSIMV, ASV, NIV, all of those things. We'll go through that a little bit.
Is that why flight crews carry Hamiltons, because you control pressure?
Only one carries that right now, but, PHI, I think just switched, Air Methods has had them, and they, PHI still got some. Main thing with them is weight and size. Those AEPs are fucking 2 feet by 2 feet by 100 pounds, so it's like a boombox from the 90s, it really is. We still have a couple floating around here, don't we? Oh, they're on the back trucks. Yeah, they're okay, they're a pressure. The problem is the user interface on those is dog. Like it looks like you're about to spool up a 737 when you start hitting buttons. So there's a lot to yeah. Pattern is full, we're clear to take off. Now, this vent over here can be intimidating when we first turn it on, but please understand, we'll get through it. I'm going to do my best to have Tyler try to get us a set of lungs by Friday, because we have Lab Friday, right? Get a lung so we can actually see now. We can take everything that we're going to learn today and see it in real time. But there's no point trying to pack all of this in one day, because as you can see, this is a very heavy topic. But we need to make sure, and this is, I cannot emphasize this part enough. I'm not saying I'm not here to help you, but you need to ask your questions today. We cannot be struggling in 2 weeks with this, going, I still don't understand this. If we don't understand this and we're trying, that's one thing. We'll figure out what works for you to understand. But if you're sitting here like a bump on a log, not saying anything, respectfully, that's your problem. Literally sitting in front of you saying, what can I do to clarify? If you were drowning in 2 weeks because you failed to ask questions, you failed to understand, that's a failure on your part, not on mine. So today is the day that we need. I'm not saying you have to be amazing at vent theory today. What I'm saying is you need to understand the concepts of vent theory today. That's all I'm asking. Or at least be trending towards understanding vent theory and oxygenation. So we're going to go to lunch. We're going to be back at you want a half hour or 45 minutes? You don't ever want to be in class. We'll be back at 12:15. Don't move. You need to come back with an open ears, open mind, and open brain, because we are getting into the oxyhemoglobin dissociation curve.
That sounded like a lot. My brain just went.
That's easier to say that than office.
What? Exactly.
What did you say?
It's easier
Talking
to
about
say.
the oxygenation,
Oxidative,
the
phosphorus.
oxidative I can't.
Relation.
Yeah, that.
Okay. We're gonna be getting in the oxyhemoglobin dissociation curve, which we're gonna have to, I'll put on the board. We're gonna be getting into mechanical ventilation. Within mechanical ventilation, there's a shit ton of math. There's no way around it. You have to do it. You have to. This is vents, contrary to popular belief, as some of my people have learned, are not a set it and forget it. This is not a Ron Popeil rotisserie. You have to do math to understand it.
Oh, hell like that?
I didn't call you out, you called yourself out. You're good with direction.
It said that some of my people, and I'm the only person up here with this corner.
To your right.
That's that corner. I'm in this corner.
So, but saying that, you've got people that have been doing this that are still understanding the concepts. Again, I'm not asking you to be a perfectionist on this. I'm asking you to understand the concepts, but we have to be involved on this topic. We have to. So if you are struggling, you guys need to take a half hour to eat, and then you guys as a class come back here and talk for 10 or 15 minutes to see what I can clarify before we get into the oxyhemoglobin dissociation curve that might be in your best interest. Because we're gonna get into, with the oxygen dissociation curve, we're gonna be getting into 2,3-DPHGs. We're going to be getting,
I don't know what you said.
Yeah, God, I think Carl fucking broke alert.
we're going to be getting into left and right shift and all of that stuff. So it's important that we're paying attention and understanding what we're doing.
Lord, me again. It'll be fine.
I'm gonna go to lunch. We take a few minutes to talk.
What time do you have to leave? 12:30? You're gonna have to give me about 15, 20 minutes to address the stuff I need to do on the service side. I'll sit down with you. And
Awesome.
I'm changing. Right.